Welcome, everyone, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for May 11th, 2023. Today's CME activity code is 488393. We've got a very interesting case today. I see someone in the text box said we should feed the case to GPT-4 and see how it fares. I think we're going to add AI as a co-host and see what they can come up with. I think it'll be fun to see how much they know, or it knows, or whatever that entity is. But that's a very funny idea. As usual, we have nothing to disclose, and also as usual, patient confidentiality is being preserved by changing any identifying information, exact laboratory dates, etc. This is a case that Dr. Whittier has. I think Bill's going to walk us through the protocol. We have 4 polls today, so we're going to have to move it along, but it's a fun case. Bill, you want to take it away?
Sure. We've got an 18-year-old guy who presents initially for evaluation of hematuria and proteinuria of around 800 milligrams, and he has normal renal function. 3 years before his presentation, he had this prolonged febrile illness of about 2 to 3 weeks. And during that time, urinalysis showed that he had hematuria and proteinuria. He also had normal renal function then. It was thought to be a viral illness, similar to like mono, but all of his viral serologies and Lyme titers and everything were all negative. His ASO at the time was also negative. And after about 3 to 4 weeks, his fevers, his hematuria, his proteinuria all resolved. They had repeated urinalysis and everything had become normal. And so they decided to not do a biopsy. So a formal diagnosis was never given 3 years ago. And then he was in his usual state of health and everything was fine. And he was getting ready to go to college and he saw a new doctor. When he saw the new doctor, they checked the urinalysis again just to make sure that everything was gone, and there was some hematuria and proteinuria there. And when it was quantified, it was around 800 milligrams per gram. He had a couple of RBCs on it, and he had normal renal function. He had had COVID-19 1 month prior to this doctor's visit, though. So he was referred to nephrology, and the nephrologist recommended just monitoring for about 6 months. And if the proteinuria persisted or increased, he would need a kidney biopsy. At the time, he was ready to go to college. He was a regular kid, no shortness of breath, no skin rash, no symptoms of any sort. He did not use any NSAIDs or herbal supplements or any kind of, weight gain supplements, creatine or anything like that. His blood pressure was always normal or low. He actually had an occasional dizziness when standing for a couple different times in the prolonged heat, and thus his nephrologist at that time had elected not to begin an ACE inhibitor and just kind of follow without. And then 5 months later, after he returned from school, his proteinuria was still present at 752 milligrams per gram, and his repeat urinalysis had 1+ blood with 4 to 10 red cells. So really no other medical history except for above. He'd never had any surgeries, no medicines, no family or social history that's relevant. His blood pressure was low normal, 105/76, and he was a tall, thin kid. He was in no acute distress. Lungs were completely clear. Cardiac exam was completely normal. No rash, no edema. Everything was normal. And so I have the labs there from 3 years ago, which showed that the ASO, that's supposed to be, the ASO was normal. The ANA was normal. All his viral serologies were normal, but he was inflamed. His SED rate was 95. His urinalysis had 2+ blood and 2+ protein. And when they had done a urine PC at that time, it was only 120. And then a year after, or a little bit of time after that, his urinalysis was negative. And then currently, his CBC was unremarkable. His chemistries were essentially normal. His serum albumin was 3.7. His ANA was 1 to 160 in a speckled pattern. But his double-stranded DNA, Smith, Rowe, Law were all negative. His complements were normal. His rheumatoid factor and cryo were also negative or normal. SED rate was now 11. His PLA2R and other workup, including ANCA and PLPR3 GBM, HIV, and hepatitis studies were all negative. His urinalysis had 1+ protein, 1+ blood, 4 to 10 red cells, and his urine PC was just stable there at 752 milligrams per gram. His nephrologist checked the urine AC as well and it was 432 milligrams per gram. His renal ultrasound was completely normal. So he had a biopsy.
Great. Any questions?
Family history was negative for any autoimmune or renal disease.
Bill, I see his 6'1", 157 pounds. He's a young man. I mean, just the eyeball test, creatinine 0.93, okay for him?
Yeah, I think so. I mean, he's pretty tall. I mean, skinny kid, but yeah, 0.93 is normal
Okay.
for him.
White, black, Hispanic. Do we have any idea?
Yeah,
Yeah,
it was in the.
Asian Indian.
Oh, sorry. Sorry.
When you say his skin had no rashes, was he examined carefully in his scrotum? What am I thinking about?
Fabre's.
Yeah,
Yeah, I don't know the answer there. So I'm sorry, I don't have that.
okay.
I already had the. Yeah, I didn't examine that.
Okay.
I'm not sure if his primary nephrologist did either.
I assume a good ophthalmologic exam was done too.
No.
You gonna start some more trouble, Dr. Corbett?
I am. I was going to ask about if you had, any kind of findings on his tongue, but I guess we'll leave that alone.
There were no findings on his tongue, but an ophthalmologic exam was not done.
All right, fair enough.
Great. Well, we're gonna start with a poll. So at this point, I would do a renal biopsy. I would do some genetic testing. I would try low dose ACE-ARB plus or minus SGLT2 inhibitor for 6 to 12 months, and then just reassess things. This has been going on for a while. Or number 4 would be some empiric disease targeted treatment, which is based on what you think they might have and that you're confident enough you might want to just go ahead and treat. So biopsy, genetic testing, conservative therapy, or aggressive therapy. The co-hosts can't vote, but everybody else can vote. We got a nice audience today, so let's see if we can get a good number of votes. Give it a little more time.
The panel can always put their comments in the chat though, if they have anything. For their poll questions, at least. Should be shared.
Yeah, we can share it.
Yep.
This is about as much a mandate we've had in a while on a poll, and 2/3 of the people say renal biopsy, and about 13% say genetic testing, and about 1/5 of them say empiric therapy. So nobody bought into the high dose therapy without a diagnosis. Usually somebody buys every option and gets somebody to bite. So our number one answer is a renal biopsy. So Dr. Corbett, I want you to discuss the differential diagnosis of this presentation and what you think.
Wow. Let me get back into where. Yeah, this an interesting case. I mean, it is interesting to me that everybody jumped right onto the biopsy. I don't know if they did just because of the fact it's being presented or if there's another reason. But I mean, when I had, as Bill was, giving the history and physical and the laboratory findings, I mean, the thing that was jumping out at me was, does this gentleman have IgA nephropathy? I mean, he's in the right age group. He's got microscopic hematuria, low level of proteinuria. I mean, that for me is kind of way up on the list. He's it sounds like he's otherwise in pretty good health. I mean, the one, I guess, serologic finding is that he's got this mildly positive ANA. So I guess the possibility of, an autoimmune disease that's associated with low level proteinuria and microscopic hematuria definitely has to be a consideration, which would be something like, I would think, mesangial lupus. I mean, you could also have, lupus membranous can have a few red cells and low grade proteinuria. FSGS seems a little less likely. He's not hypertensive. He's non-nephrotic. I mean, I guess you could have it, but I'd think more of a secondary form of FSGS, and I don't really have any reason to suspect that he has one. The Fabre's is obviously interesting. There was no history of, any pain type symptoms. He had no angiokeratomas, as Dr. Glassick appropriately brought up. I mean, you would expect to have seen some sort of a skin rash. there's no real family history of any kind of renal disease. I don't know. For me, obviously the biopsy is going to be key here, and goodness knows what you're going to find, and we can always be surprised. But I mean, on the surface of this, I would say IgA nephropathy has to be way up on the list for me, and a distant second would be autoimmune disease like lupus.
Casey Gashty, what do you think?
I agree with Steve. I think it's a young man with a pretty normal kidney function, has a little bit of proteinuria and hematuria. I think IgA is pretty up there. Just from a statistical standpoint, that's one of the most common glomerular or causes of this type of presentation. I think this fits here. So I'm going to go with IgA. I don't have anything to add to his differential.
Yeah. So in the chat, somebody brought up Alport. I mean, I think that would be unusual not to have any hearing loss at this point, but I suppose it's possible. But what about thin-basement membrane disease?
Well, good point. I mean, that'd be the autosomal Alports is what they were talking about now, as opposed to thin basement membrane. They're trying to change the nomenclature. I guess that's, that would be a possibility. It's usually autosomal dominant. There's no family history, but I guess that is a possibility.
I mean, the thing about family history of a relatively benign disease is that you can have a family history and not know it. So I don't think you're going to have a family history of Alports and not know it, but I think with, thin basement membrane or whatever the new terminology is, which Autosomal
Alports.
Autosomal Alports, okay. So that's, I think, in the possibility too. There's some other things, collagenopathy, IgA, ALECT amyloid, I think those are all interesting. Anybody, Dr. Glassick or Dr. Reen, you have any strong feelings about the diagnosis?
Roger, what pointed me away from IgA nephropathy was the fact that he has symptoms of orthostatic hypotension and an unexplained febrile episode, both of which are seen fairly frequently in Fabry's disease. A patient with IgA nephropathy that has this degree of proteinuria, I would have expected at least mild hypertension and certainly not orthostatic hypotension. I agree that ANA is troublesome and he's not on any medication that would explain that, but I have trouble thinking of what kind of autoimmune disease he might have that would present with asymptomatic proteinuria and hematuria with no other serologic manifestations. I went with genetic testing, frankly, although I must agree that a biopsy in this case will probably give diagnostic clues, but I'm just intrigued with the history. I mean, this may sound like going for zebras when you hear hoofbeats, but I think this is a young male, with these two clinical findings that makes me suspicious.
I think that's reasonable. And I mean, genetic testing is a lot more benign than a renal biopsy. And, we may get to the point where that is a fairly routine test before a biopsy in a lot of patients that don't fit a, obvious lupus profile or something else, especially this one, where you're talking about, autosomal recessive Alport and IgA, et cetera. So it is kind of interesting. I think we have another poll. Is that right, Pravir? Before we spin the wheel?
Yes. Yep. Another
Okay, so
poll.
before we actually see, we got another poll. What do you think, people? What do you think the biopsy will show? Number one, thin basement membrane disease or other type 4 collagen disease, IgA nephropathy, C3 glomerulopathy, an SLE-related lesion, or Fabry disease.
Well, the way this conference goes anymore, you would definitely be way up to pick the most obscure diagnosis you could find. That's why I think Dick may not be too far off, actually.
Well, that's always the problem. I mean, it's but I like people to just try to answer based on not guessing the zebra.
His
But
his
they really
primary
think it's gonna
nephrologist
be-
who's on the chat and I discussed it in advance at the 6-month point before we even got to the biopsy, and we both agreed like it's overwhelmingly IgA nephropathy, and let's just watch the kid for a little bit, and if he comes back and he's a little worse, we can biopsy him then. It didn't seem like there was any urgency, but both of us were thinking IgA for sure.
Yeah, and that's what it screams to me, a young person of Asian with mild proteinuria, hematuria, you know.
Pretty good participation here. I'm gonna end the poll and share.
It says in the chat, it says hoofbeats at Rush Biopsy Conference don't indicate zebras, they indicate unicorns. Okay, well, touche. IgA nephropathy is still number one, and then comes a thin-based membrane disease, and then Fabry, and actually lupus is last, which is interesting. But that's what we have. So again, of course, that's why we do these things, because we don't know what's going on. But it's a nice differential diagnosis. I think we'll spin the wheel and see actually what the biopsy shows.
Yeah, and Dr. Schlieben sends his cases to Arcana. So we have a visiting professor from Arcana, a pathologist, to help our fellows or whoever gets picked to read through the biopsy together.
Dr. Radvi, I have a comment.
Yes,
You know,
Dr. Reen.
He's a Indian Asian, right, Dr. Vitya?
He is, that's right.
Yeah, I tend to agree with Dr. Glossick that to me, I'm thinking more Fabry, because South Asians, especially Indians, actually, their disease is IgA is a little bit more aggressive. I would have expected a little bit more proteinuria in him over a period of 6 months. I would not have seen it just standing there and not moving up, because it's a little bit aggressive disease especially from North India.
So he has no rash, he has no cardiac disease. He's got, no symptoms of, pain related to various, issues.
I
et cetera.
understand that, but patients have been described, either we've missed them, but seen patients with Fabry disease who will present with proteinuria and hematuria, and there are no other skin lesions or neurological symptoms. I never got them to have fundoscopic examination, so I cannot say about eyes, but the patients are reported unless we are missing the physical examination. It's just a point of discussion.
No, it's a good one. And I was just saying that to get you to say what you said, and that, because, for years, people have said it's an underdiagnosed problem.
Mhm.
Dr. Reen, would you have biopsied or would you have done genetic testing first?
I actually went for genetic testing because I was thinking more like Fabry's disease, to be honest with you. And
Let me ask you, Roger, if this patient had an autonomic neuropathy diagnosed by doing appropriate Valsalva maneuvers and upright blood pressure measurements, would that change your differential diagnosis?
Well, I certainly would jump on genetic testing earlier too. Yeah.
Right.
And I also wonder in India, although I think it's northern India where we see a little more ALK2 amyloidosis.
yeah, it is an area called Punjab, which
Punjab,
is,
yeah.
and there is also in Bangladesh, also Egyptians and Hispanic, of course. But the first case, if I recall, was described from Bangladesh, and second or third case was from Punjab area of India.
Great. Well, the wheel is screaming to be not ignored any longer, so we're going to see who's going to read it. Neelam. Neelam is one of our first-year fellows. The wheel has been avoiding her up to this point, so take a deep breath.
You can only be avoided so long.
Yeah.
And let me introduce Chris Larson, who read this patient's biopsy from Arcana. Thanks for zooming on with us today and helping us out.
Yeah, glad to be here. Congratulations, Neelam, on being selected today.
All right, Neil.
Chris, your goal here is to be as nice as David usually is. So,
All right, Neil, I'm going to give you control. Go ahead and click on the screen. Yep, you're controlling it. Remember, there's a lag. You see on the left. Oh, give me 1 second, Neil.
yeah, we have to have the proper slide with introducing Dr. Larson there. We got.
Can you hear me?
You're echoing. You want to try it
There's a
again?
little echo.
Better?
Yeah, you're echoing.
Am I still echoing?
No, you're good now. Okay, I'm gonna give you control again. Go ahead and click on the screen. Yep, there you go.
Okay. So here we have one, it looks like a core. It's on the PAS stain. Looks like a pretty good sample with 5 glomeruli present, and the tubules themselves look pretty back to back. Don't see any infiltrates. And then the gloms at this high power, I don't see anything like in particular standing out. Maybe this one looks a little bit more with some mesangial expansion, but we'll see them on the low power. I mean, and then here we have the H&E stain. Again, it's at low power and we see 3 gloms. And this, maybe this one looks a little bit more with some mesangial expansion and some hypercellularity around here. But again, we'll see them on higher power, so I'll comment on those at that time. The tubules here look back to back, and I don't see any infiltrates either. Other than that, nothing else stands out at this point.
Nilam, are there some red cells in the tubules there? Because that would be
Yeah.
worth noting.
Yeah, they look like there's a lot of unlicensed RBCs.
Sorry, I mean in the tubules themselves.
Yep.
Chris, is that the case? Not an actual cast maybe, but some red cells there?
Yeah, there are. You're doing a great job, Neelan. I mean, I think you could switch to renal pathology if you wanted to. I can tell you got a knack for it. But yes, there are a few renal red blood cells present there in the renal tubules. Since they are not true casts and since they are fresh, that sometimes can be just an artifact of the biopsy. So at this point, I would want to see some true casts or some aging red blood cells in there to really know whether to really try to make up my mind if they're true glomerular hematuria causing those red blood cells there. But it was a good pickup. Yeah, good to note that.
Okay. So moving on. Here we have a high power PAS stain with 1 glomerulus. The basement membrane looks intact. Otherwise, the loops themselves are pretty open. Maybe there's some thickening over here of the capillary loops, and then again, some mesangial expansion and some hypercellularity in these areas. And then the tubules, I don't see any sloughing. The basement membranes look intact to me.
You mean the brush border?
Yes, sorry, brush borders. So again, we have another glomerulus on high power PAS stain. This basement membrane
This
looks.
one's H&E, isn't it? Or is it PAS? I may be wrong.
That's PAS.
Okay, sorry about that, Nilam.
The basement membrane again looks intact. The capillary loops also are open, and I don't see any like thickening of the capillary loops in themselves, but there is some hypercellularity as well as some mesangial expansion. Again, as we previously noted, in these brush borders on these tubules, maybe there's some sloughing over here. But other than that, I don't see anything in particular standing out.
Neelam, do you see that there's a loop at around like 1 o'clock that, I don't know if I'm just overreading this. Yeah, right there. You see there's the pink materials like dark pink, light pink. So there's something I feel like in that basement membrane. I think there's, if you look a little bit further in, there's also some, I think, obviously the Jones stain and IF will clarify this, but you can see some subtle things that are not normal with the capillary loops, I feel. Am I overreading this, Dr. Larson?
I agree. I mean, that's not something I would expect, a renal pathologist that would kind of jump out at, but if you don't stare at glomeruli every day, then I wouldn't expect you to see that. But yes, I would say they're a little bit prominent is the way I would term it.
Okay, so moving on to the next slide. Here we have the Jones or the silver stain. Here we'll look for any holes or breaks or spikes. Yes, like immediately I think these were some spikes over here, and then maybe here as well, and here. I think they're pretty much like here as well. I don't see any breaks in particular, any holes, but I'm not the best at looking at holes.
You're doing great. Now you're picking up this. So now your glomerular basement membrane, the prominence of them is starting to make sense because you can see that indeed there are spikes present here, definitely.
Dr. Larson, if you were just shown the Jones slide, how can you differentiate the spikes from membranous from the eyelashes of amyloid?
Well, the spikes look very different. There are some, there's one little area of the mesangium here, kind of paramesangial region, and it's almost in the middle of the slide. That is reminiscent of eyelashes. And I thought that same thing when I looked at this. But usually eyelashes are much more discreet than this. I mean, they'll really truly look like eyelashes. Here, the mesangium looks like you kind of have spikes coming out of the mesangium in this one portion. But these extend out along the glomerular basement membranes, and they're very irregular. Usually eyelashes are very uniform. So it has it's a different look. It's a subtle difference, but there's definitely a difference. So yeah, what you're seeing here are definitely the features of subepithelial deposits more than what you would typically see in amyloid.
Chris, when you see these eyelashes in amyloid, can they be in all types of amyloid or just AL?
They are almost always AL. Yes, it's usually in amyloid that has a rapid deposition. So, things that are very more slowly progressive, like the LEC2, like the AA, very unusual to see amyloids. In fact, to see eyelashes. In fact, if you saw them, you would immediately suspect that it's not that. It must be AL.
So moving on to the next slide. Okay. This is like the trichrome stain with one granulus.
Look at all that. That's very impressive.
There's the capillary loops are all open. It looks like maybe there's like some thickening here, and then are these some deposits over here?
Yeah, exactly. So now you're actually not just seeing the spikes of the basement membrane, you're seeing the actual deposits, these here on the trichrome, they're red, that are present under the, on the subepithelial aspect of the GBM. So it's very rare to have deposits. So deposits have to get quite large in order to be able to see them by light microscopy, but you're right, you can here.
Really? Are these some more over here as well?
Yep. Occasionally you can see the individual deposits here, even kind of, I'd say, just above the center, there's a loop where you can see kind of individual deposits along a capillary loop. So this is not something you commonly see by light microscopy.
Okay, so the immunofluorescence is negative for IgG and IgA. So this is C3 positive along the capillary walls, and maybe some in the mesangium as well in the pop.
Yeah, some mesangium. I'd say like this looks mesangial predominant with maybe some segmental capillary loop. So it doesn't look like all the capillary loops are involved, but definitely some of them are.
So the intensity there is at the vascular pole, I take it, right?
On the left, yeah, exactly.
Okay. It's both kappa and lambda are also negative. Okay, and then on the immunofluorescence, it's only positive for for C3, it looks like.
The other stains were done, which were negative. That was
Was the pronase done?
no. So what do you see, Neelam?
So this is the EM. So this is the blood space and urinary space. Right off the bat, you can see a lot of deposits. These all look subepithelial. Maybe this one's like intramembranous over here. And then the foot processes in themselves, I think they don't look effaced to me.
The one is just massive, though. It's almost like a subepithelial hump.
I think it is a hump.
It looks like a hump.
Mhm.
Yeah,
Humps
only
out.
C3, and only
Yeah,
C3
you can tell why you can see them by light microscopy, right? I mean, they're just huge.
Okay. Again, it's the blood space and then this the urinary space. And then again, you can see all of the subepithelial deposits, including this larger one over here.
What about the foot processes?
Maybe there's some effacement over here, but they look maybe a little bit larger than I would normally expect them to be, but
I mean, to me, it looks like they're effaced over the deposits and they're not effaced
Mm-hmm.
over where there aren't deposits.
Yeah.
But I might be overreading it a little bit. Oh, if you look here, it's really nice. You can see what forms the spikes, the spikes are the basement membrane going between the deposits. So we saw that earlier, you pointed them out, but here's the EM equivalent of it, at about, 10 to 12, really nice. So you're gonna have to tell us a diagnosis here, Neelam.
guess.
Good luck.
Well, Neelam, you describe what you saw. That's all you need to do.
Yeah, it's always a pathologic diagnosis.
I mean, I guess on the poll, when we know that it's not IgA since that immunofluorescence was negative. And then I know we considered amyloid, but we didn't see any like positive, like full house or anything like that to be able to say that. The immunofluorescence was positive for C3. And so it's like C3 GN would be probably like higher on my differential.
Neelam, what additional staining would you request of the pathologist in this case?
Neelam, you're allowed to. You're going to pass on that. We're gonna poll people, but we're gonna pass on that for now.
Okay.
All right. You owe me one, Neil.
Yeah,
so,
great job, Neelam. You did a
yeah,
good
that's
job.
fantastic. Great read. Applaud, applaud, applaud. So it's odd because you've got this, it looks C3 is the only thing that's showing up, and these big humps which have been described in C3, but there's something, So let's get the next poll. So what would you do now? We've got MMF, treatment for C3GN, your complement pathway evaluation, or conservative therapy again. Remember, this guy really doesn't have much of clinically going on. Refer to a C3GN trial or other, and just other, if you have something in mind, we can ask later what this is, what people have, what the other might be.
Yeah, maybe if you put other, you can put it in the chat what you'd like to do.
But wait 1 second for people to vote.
Yeah.
But you can put it in there.
It's important to point out that the electron microscopy did not show any zoonosis. No zebra bodies.
Yep. All right, we got a pretty good, yeah, I got a pretty good couple more seconds. Yeah, so complement pathway evaluation and along the line of the C3GN. 30% said conservative. 13% said C3 trial, about the same as MMF, thinking that let's just go ahead and treat it as C3. We don't need anything else, and others too. In the chat, we have not Fabry's, yes, and pronase digestion, which is a thought as well. We'll see if that's relevant in a minute. Dr. Whittier, you want to take it over for a second?
Yeah, that sounds good. Let's see here.
Should I give you control?
Yeah, that'd be great.
Okay. Go ahead and click on the, yep, that's you.
So without having to ask, since it went to Arcana, when Chris saw this, he thought, well, there's something funny because there's something in the glomerular basement membranes. These deposits are there. They weren't really lighting up fully on the other immunofluorescence. IgG was negative. It looked more like a membranous. It didn't seem the classic C3. So what if there's something else there? And so after he did pronase digestion on the paraffin block, he found out that IgG became unmasked, as we have here. And so, yeah, I think the other that was really necessary in this case was the important thing, is to find that this actually is an unmasked IgG membranous. And also during the unmasking process, there was a kappa light chain restriction with the lambda being negative. So in that situation, let's do another poll. And I'm not sure I can run the poll, Pravir. Maybe you have to take it over.
I can
do the poll. Yeah.
So knowing that this is a membranous, and remember the PLA2R was negative, the initial IgG was negative, the NEL1, exostosin, thrombospondin, all negative. His PLA2R was negative in the blood. The IgG was subtyped and it was 1, because that was just asked. So what would you do now? You've got this kappa unmasked as well. Will we do a malignancy workup? Will we do serum and urine fixation with the serum-free light chain analysis, or straight to bone marrow looking for the clone? Or we'll throw other on there if you want to put some other things in the chat.
All right, give it a few
I
more.
suppose you could have added a fourth option here, do nothing.
Yeah, it's funny. I had that on every other poll, but I left it off here.
All right, I'll end it there and share the results. So the majority, 49%, went with blood and urine immunofixation and serum-free light chains. Second was bone marrow biopsy looking for a clone, and the minority was a malignancy workup.
So before I hand it back to Bill, I just want to, point out that where we've gone these days is that anytime we see light chain restriction anymore, we just automatically assume that this is a clonal disease. I think this is what a lot of people would do, is they'd say this has to be a clonal disease. Let me look further and look for the clone. You could either start with immunofixation of the serum and urine and free light chains, or go directly to the bone marrow. A lot of times when we find these clonal diseases, these monoclonal gammopathies of renal significance, you can't really find anything anywhere sometimes, certainly not in the serum, and sometimes not even in the blood. So that's kind of where this looks like it's directed, but it also has this odd membranous pattern, which is not typical of proliferative GN with monoclonal immune deposits. So before I say anything else, I'm going to hand it back to Bill.
Dr.
But Roger,
Yeah.
let's not forget the fact that this patient has a positive ANA unexplained.
We have a positive ANA, but without anything else, immunofluorescence wise, I don't know. I don't feel real strongly about that diagnosis without something, without anything else, without,
No, but that's but a positive ANA is part and parcel with this disease.
Okay, I'm sorry. Thank you.
Was the serum amyloid protein done, Dr.
Well, yeah, so let me kind of tell this story a little bit, and we'll get to that, Dr. Reen. Thanks for bringing it up, and also those that did. You know, this disease was really, you know, this is the other reason to have Dr. Larson on. I'm going to tell one of his many stories, but this is going to be one. So please correct me if I tell your story incorrectly, okay, Chris? But originally described in 2014 was this membranous-like glomerulopathy with masked kappa deposits, and it was basically the same story that we told today. It was a case that looked like C3GN, but there was something a little bit funny like it in it. And so once pronase digestion was done, they unmasked the fact that IgG1 was present and kappa was often present. They had about 14 cases originally described again in KI in 2014. And it was typically a young female disease. And a lot of the patients had an ANA positivity or some sort of mild, you know, inflammation or some sort of lupus-like syndrome. The average proteinuria was similar to what we had in our presentation, and with a kid with normal renal function. Males can have it; it's not just females. In our case, of course, was a male. The morphologic features on the initial biopsy showed that, just like our case, there was fresh IgG, which essentially was negative. C3, fresh C3 was positive. Many had hump-like deposits. And then after pronase, you'll see that after the pronase IgG and the pronase kappa, they all became positive. And so they didn't really know what this disease was or where it came from, but it was clearly a new pattern, and it was a membranous kappa that only existed after pronase digestion. And so they had a follow-up study a year or two later that basically had, now I think it was 40 cases or something. I think there were 41 cases, and this is data on 27 of them. And they wanted to basically describe how these patients were treated, what is this coming from, and also what the pattern was, and kind of expand their expertise. And so the same cases, and they were calling it MG-MID, which is membranous glomerulopathy with masked IgG, or with masked kappa deposits. They got treated in a variety of ways. Many got bone marrow biopsies. Many had serum immunofixations done. All of those were negative. It does not seem that, even though kappa was in the biopsy, that it was coming from the bone marrow at all. So no one really knows where the cause of this was coming from. But there were a lot of different treatments that were used, from none to ACEs and ARBs alone, to steroids with CNIs, MMF, Plaquenil, rituximab, azathioprine, and rituximab alone. And there wasn't anything that was sort of consistent in the therapy, which seemed to have made a difference. The clinical outcome by treatment really, I think, it had a lot to do with the serum creatinine at presentation, but there wasn't really a certain treatment that seems to work for these patients. So we've talked several times in this conference about pronase digestion to the rescue, and I think now we've finally completed this chart. So we've used it when the frozen is not available, which is the most common, you know, initial thing, when IF isn't available, and you can use it to back into an IF. We had a case of light chain proximal tubulopathy, and we've had crystal globulin and crystal cryoglobulin induced nephropathies. We've had MPGNs with negative staining initially for the immunoglobulins, making you think that it's more of a vascular type of MPGN. But then when you do pronase, you find out that that some of the immunofluorescents are positive, often with complement mediated issues where that kappa or lambda can even activate complement. We've discussed that. And then C3GN associated with monoclonal gammopathy or an autoimmune disease as well. We also have had a fibrillary GN with apparent monotypic IgG deposits. And so this is our first at the biopsy conference here at Rush with our membranous nephropathy with negative or weak staining for IgG. So this fits really well into this category of what we had in our case of when you make sure to send for pronase digestion. Then in 2020, this same disease, what they did is, we still don't have that much data on where it's coming from, why it happens, what are the proteins associated with. So they did mass spec on the tissue of the patients that they had with this disease. And what they found is that mass spec revealed that the serum amyloid P component was positive in all those biopsies. And I'm going to get to the serum amyloid P component in a second. These were all the biopsies that they looked at. And what they found is they tested them for serum amyloid P, and they found out, not surprisingly, it was positive in amyloid patients, okay, negative in fibrillary, and it was positive in some of the patients with the IgG1 kappa, okay, that was unmasked, and it was positive in all of the ones that he had described here, okay? So what they found was that this disease is associated with a serum amyloid P component. So that kind of, and then this is sort of a big representation of the, yes. Of the
Can you go back to that?
Sure.
What is the difference between the top, on the right-hand column, the top two, or at least, yeah, the top two, and when now they call it MGMID?
Chris, do you know that? Because could you explain that? He's saying, what is the difference between the top on the right and the MGMID?
Okay, yeah. So what the top on the right, what you have there are cases that are membranous pattern with IgG1 kappa staining by routine immunofluorescence, meaning unfixed frozen tissue, and they're not masked. In other words, they're staining by routine, and occasionally these IgG1 kappas that are not masked are SAP positive. You can see the other membranous patterns that have other IgG subclasses and types, do not show that same thing. So, membranous MGMID is when you can detect an IgG by routine, it's always IgG1. It's always IgG1. It's always kappa. So these are there's probably some, initially we found these cases that were completely masked or nearly completely masked. Probably the spectrum of the diseases is a bit broader. And sometimes the cases show, do stain by routine, but are probably the same disease process.
So Chris, in at least in amyloid and some other things, serum amyloid P protein, I thought was in some way related to the fibril formation. And these deposits have no organization whatsoever, right?
Yeah, no, SAP is present in amyloid. It's always present in amyloid of all types. The exact reason for that, I don't know, and I don't know if anybody knows, but it is true. However, it's not specific. I mean, SAP is a protein, circulates in the plasma, it's produced in the liver, pretty high levels in the plasma, actually. And it plays despite the fact that it's present at pretty high levels, we don't know exactly what it does. It probably has some role in the innate immune system. Structurally, it's very similar to C-reactive protein, an acute phase reactant, so perhaps there's some similar functions, but similarly, CRP, we're not really sure that, we don't know that much about really. We use it diagnostically sometimes, but yeah, so it is, it is useful for amyloid sometimes, particularly on mass spec, but it's not specific for amyloid.
No, but you don't see much of it here, but I think it was Hawkins in UK have radio labeled SAP, and in their patients with amyloid, they actually follow their deposits based on the fact that there's a fairly high concentration of this in the amyloid deposits.
That's right. It does deposit with amyloid. Amyloid is actually, we think of it as one protein, but amyloid is actually many proteins. And there are some proteins that are kind of ubiquitous in amyloid. SAP is one of them. Others are like ApoA4, despite the fact that it is a type of amyloid, it's always present in all types of amyloid. So
there were reports years ago, I remember, of some of the fibrillary GNs, if you will, that they found serum amyloid P protein in it, and they thought that might be in some ways instrumental in the formation of the fibrils. That's kind of why I was asking about, these have no organization whatsoever, and yet they're very rich in SAP.
Yeah, I know the report you're talking about. It was from the 80s, I believe, but that has essentially been disproven. You do not see SAP in fibrillary deposits by mass spectrometry.
Fair enough.
Right there, yeah, shows that same thing, that they're not present in fibrillary GN. And so yeah, so the first thing I think is how they found it, of course, is that they found that the patient's SAP stains were positive, and then in the patients that had the IgG unmasked and they had SAP, when they merged, there was co-localization there. And in the case of SAP negative, when they merged in like a PLA2R positive patient, there was no co-localization. And so it's really isn't a SAP wasn't positive in all the patients with membranous. It was really only positive in these ones that had the mass deposits. And then of course they found out that it was also positive in some patients that did not have the mass deposits. So they had originally called this disease, membranous with masked IgG kappa, but now there's a little bit of a conundrum because this same SAP was positive in some of the ones that was unmasked. And so now one of the points of this paper is that we really should be calling this an SAP positive membranous, which is what we now are calling it. So it just to go over exactly what Chris had already said, it just bears, I think, repeating that one, this is not SAA protein that we would see in secondary amyloid. It's different. This is in all amyloid proteins, and it's not in the fibrillary ones. Not sure what it does, but again, just like Chris said, it seems to be involved in innate immunity. And when complement's activated, this is sort of revved up like an inflammatory marker. Not all the cases have mass deposits, so we can't really call this disease the masked IgG kappa disease anymore. Although if you do have the masked one, you could call it that, but that also is going to be SAP positive. And the other thing here is we don't know how to treat them, but we do know that it's not associated with lymphoproliferative disorders. So even though kappa is part of the thing in the kidney biopsy, this does not, as of now, belong in the MGRS category. And so we don't need to go searching for bone marrow biopsies and so on. This patient actually did have a serum and urine fixation that was negative, and their serum free light chain was normal. So lastly, in this case of our guy here, we did the co-localization of SAP, and it was positive in this patient in the pattern of the same deposits that we saw on the trichrome and on the Jones stain and on the IgG1 that was unmasked.
So that nails the diagnosis. I mean, you've described it. It shows everything that Chris described. It pretty much fits into exactly what Chris described. Chris, is it the serum amyloid protein that's masking somehow? Do you think that's it, or do we know what masks what masks?
No, this whole masked phenomenon, this was the first masked glomerulopathy that we knew about. Whenever we identified, this is definitely a unicorn somebody put in there. Whenever we first saw this case, that patient 2 on the slide that you showed, that 17-year-old female, was the very first patient I ever saw. It came across my desk, and it was a young female that had C3. It was just like this, C3 only staining, but a membranous pattern. And I just thought, for sure, this must be something happened. Somebody mishandled the tissue. Perhaps they put the tissue that should have gone into Michelle's or saline into the formalin and then put it back. Something went wrong. And so I just thought, I'm going to just stain this by paraffin immunofluorescence just because I can, just to make sure. And when we did, it unmasked. And so we thought, oh, great, we got the diagnosis. We switched. I didn't believe it was a C3GN. It didn't look like a C3GN, but it was C3 only staining. So when I got the paraffin immunofluorescence with the IgG, it all made sense, and I just called it membranous and went on. That patient too had ITP, the 17-year-old, and she was on IVIG, and I thought, maybe this is an IVIG phenomenon or something. And then about a month later, one of my colleagues, Jane Bell, came into my office, and she said, Chris, I got a patient just like that one you saw last month. Membranous pattern, it's not staining. And I said, oh, they probably messed up the tissue. The last guys denied it, but I bet you somebody mishandled the tissue. Why don't you go ahead and stain it for paraffin IF? And same thing happened. There was no unmasked. That term didn't exist, but we just said, oh, okay. So anyway, one after another, over the next year or two, we start seeing this, and we start recognizing, oh wait, they're always young females, almost always. They usually have some vague autoimmune phenomenon, ITP or some positive ANA or something. So we described this mostly out of a desire to say, don't mistake these for C3GN, because they're not. They're something else, you know. And also, they may have kappa only, but they're not MGRS, which that didn't really exist either back then. But it was at that point in time that I realized, well, if this disease masks, it's possible other diseases mask too. So anytime we got something that didn't add up on the routine IF, we'd say, well, let's just stain it by paraffin IF. Let's see what happens. And we started realizing, oh wait, some of these cryo cases unmask. And you know, occasionally one of these MPGNs will unmask, but there was a common theme among the things that unmasked. Things that unmask are almost always light chain restricted. You know, even the type 2 cryos, you know, those have IgM and IgG, but they have a monoclonal IgM that's targeting a you know, so there's still a monotypic process present. So whatever's happening in this masking phenomenon, which masking, all that really means is you're getting a false negative staining on the routine IF. So that false negative staining is somehow associated with the presence of a monoclonal immunoglobulin present the vast majority of the time. So I don't think it's SAP related, but honestly, you know, that's what people always ask. Why are these masking? And the short answer is, I don't know.
So is SAP an acute phase reactant as well?
Yeah, good question. I'm not sure.
You know,
I
like
don't know if
SAA protein, I just wonder if there's some inflammatory condition that we're just not able to pick up in somebody like this that
Yeah.
may be responsible for generating. I mean, I don't know that anyone, have you ever actually had a serum sample where you were able to look at the level of SAP in the serum?
You know, no, I've never measured that. I would say there's a good chance this could be a target antigen in these cases of maybe these patients form autoantibodies to SAP. But it's also possible that for whatever reason, this IgG kappa binds SAP in the same way that some things bind complement. You know, some immune complexes include complement. So I don't know that it's an autoantigen, but it's still possible. We're kind of testing that in a couple of different ways right now, but thus far we haven't been able to prove that it is.
Dr. Larson, I have a question from you. You helped me make diagnosis from Toronto. I hope you remember about 3 years ago. And I spoke to you personally. And I seem to recall read a paper when I was reviewing this patient of mine too, with similar disease. There were some patients described with viral infections which precipitated this disease. Am I right, or I'm thinking something else?
No, not to my knowledge. That's not one of the things that precipitates this. It's possible. I mean, that is one hypothesis we've always wondered, is that could there be some sort of viral precipitating infection? But I have not found any theme among the patients. And, you know, you mentioned that 30 or 40 patients in the last report. We've seen hundreds of these patients now, two or 300. So we're in the process of putting together a larger case series. And I think there may be some signals for treatment in it, but we're still working on that. But, you know, this is probably way underdiagnosed. I mean, there are I know nephrologists that cover 3 or 4 of these patients. They're usually pediatric nephrologists. You know, you're going to see it more in that younger subset. But we diagnose it about as much as we diagnose fibrillary. So if you know, fibrillary is not common at all, but it's also not vanishingly rare. So it's not like collagenal fibrotic or something. So these probably are more common. I think it is probably still under-recognized.
Chris, I have a question for you, mainly because of my interest in naming nosology of glomerular disease.
Yeah.
As you look back on this, would you have been happier if you had called this atypical membranous nephropathy?
Something like that.
As you have shown, the electron microscopy of this disease is very much different than garden variety membranous nephropathy. These humps that are seen and the irregular nature of the deposition and the bright staining by trichrome is so different than what we see in standard issue membranous nephropathy. I think atypical membranous might be even a better word.
Yeah, definitely the name is it's not perfect. When I first wrote that first case series, I actually called it, I wrote the case series as monoclonal membranous-like or monoclonal masked membranous-like glomerulopathy. And I did that because I wanted to call it triple MG. So if you ever visit Arcana, anytime we show these in our conference, we still call them triple MG because we were calling them that for years before the publication came out. It took 3 or 4 years we were seeing this before publication came out. But the reviewers forced me to change it. They didn't like that. So I changed it to MGMID. In the next, in that last SAP paper, when I realized, oh, wait, it looks like some of them aren't masked. I tried to change the name at that point, but then the reviewer said it's too late. You can't change the name of an existing entity. And so I choose to pick my battles when I publish. And I didn't care that much about what the name was. And I could see their point that it was named and all of that. So we just stuck with it. So yeah, maybe it's a nod to the history of the disease, and how we discovered it. But, it is a bit, I will agree, it is a bit unfortunate. And I do wish it had a different name, that something more generic like that atypical membranous with, IgG kappa restriction or something like that,
And the letters keep adding up once you start adding SAP to it as well. But Chris, this is your disease. You should be allowed to call it whatever the hell you want to call it. In fact, in the chat, somebody suggested Larson nephropathy, and that's what I vote for, Larson nephropathy.
Yeah, it's like PGNMID. I still call that Nasser disease, around here. I think everybody does, But no, I mean, yeah, I agree. It seems like you should be able to, but usually the reviewers make good points, and it wasn't a hill I wanted to die on. I guess you'd say that,
I know you pick your battles is absolutely one of the wisest things that I can ever tell anybody. You said you've seen, I don't know, hundreds or 1,000 or something cases of this, and this is our first, which is humility on our part and amazing on your part, and it really makes the case for a place like Arcana being such a central lab that not only gets the quantity that they able to realize when something's a zebra or a unicorn, and take it to the next level, as opposed to this gets lost somewhere else. And the good news is that you guys are very intellectually involved. You're not just describing something, but you're thinking about the pathophysiology and taking it to the next level, and we're thankful for that.
No, thanks. Yeah, that is I'll say what made it possible was the fact that we have what you guys are doing right here. We have a daily case conference where people bring unusual cases or cases that we have questions about, or, we call them show and tell, just interesting cases. But what happens is you start, I don't think we ever would have really identified this if the volume had not been so high that we'd seen it multiple times kind of in a short period of time. But the B, we were getting together every day and saying, hey, here's one of those weird cases. And if any one of us had seen one of them, it would have just flown right by. But the fact that we were talking about it, it was kind of the wisdom of the crowd that made it possible.
That's exactly my point. And that's Bill and I have been to that conference. It's a joy. It may be show and tell, but show and tell then becomes a case report, and then becomes a series, and then becomes a pathophysiology. So kudos to you guys.
Thanks.
Bill, I know you really didn't get into treatment. I thought when you showed the prognosis slide, it was pretty good. There were no ESRDs. Chris, do you have a better sense of the long-term prognosis of this?
Some of them do progress to end-stage kidney disease, and when they do, this can recur in the transplant. So we do see recurrences occasionally. So it's very difficult. It's kind of like membranous. I mean, how the rule of thirds with membranous, it's very difficult to predict who's going to respond and how they're going to behave. Now, about 20% of them have crescents, and it does seem like those cases are a little more aggressive, as you might expect. But apart from that, these are just usually, they can be kind of slowly progressive. So the follow-up here on these cases is probably an average of 3 or 4 years, but I wouldn't be surprised if it didn't look a little worse if we followed them all up now. So, and
So-
in general, I tend to think of this as, we don't know exactly what type of autoimmune disease it is, but I do think, but it does seem to have, it does seem to be an autoimmune disease of some sort. So I usually say, I can't tell you, I can't tell you exactly how to treat this patient, but if it were my daughter, I would want her treated with some immunosuppression, especially if there was any chronicity present, because, a 22-year-old young lady should not have any glomerulosclerosis. So if we're seeing that, the patient should be treated, and that's just my opinion.
Yeah, well, your co-presenter here, Dr. Whittier, his nickname is Rituximab. Simply for that reason. Bill, what are you going to do for this patient?
Yeah, I mean, what we thought was it's really not known how to treat, and he was doing really well, but we thought we were going to give him another 6 months, get through 1 full year of freshman year of school, and see him again. And if he still had that same amount of proteinuria, I mean, you would argue not to treat membranous at all with anything but an ACE inhibitor with that level of proteinuria. But since this is really unknown and he is so young, if he still had that same degree,
Yeah.
we were thinking about giving him Rituxan. And that's just based on how I think Rituxan works in other cases of membranous, even in lupus membranous, I think it works quite well, although that hasn't been described as well as the classic things that you would treat lupus with. So yeah, that may or may not work. That was my expert opinion, which is,
Yeah, the thing in this biopsy, there was no hint of chronicity. There was no interstitial fibrosis. There was no glomerulosclerosis. If there was one, you were going to kind of sit on and just watch and hope for a spontaneous remission. This would be one that you'd want to do that.
Dr. Whittier, I can tell you experience of one case of mine. I followed that boy for about 3 years now, came with the N positive, proteinuria of about 3 gram and creatinine in Canadian units 257, which is close to 3. So we treated him with the steroids and Cellcept. His proteinuria did improve, creatinine did improve, but he became diabetic. So we switched him to rituximab. And although he's not entirely aproteinuric, he still has proteinuria of about 1 gram, but I persisted with rituximab. And my logic was that he has already established chronic disease and he has a significant proteinuria. It partially did work. So I think, although I have one experience, but it may be helpful to you in future in the treatment of this disease. But I still believe the autoimmune process is triggered by some sort of external stimulus, such as infection, sort of thing which we don't know. I'm not sure the fever of unknown origin, our real fever of unknown origin, or we miss the diagnosis of something like any viral infection or adult onset still disease. I don't know, but that I always worry about these patients quite frequently. And this guy is doing quite well for last 3 years. So I will encourage you to think it.
Thank you. Yeah, we'll do. Yeah, we're following him, and so far things are good. But I've got a pretty quick trigger to give him some immunosuppression.
As Dr. Glassicos says, it's an evidence-free zone, and he's a real stickler on evidence. But sometimes you don't really, you have to make a decision as a doctor. Dick, would you treat this guy, or would you watch him for now?
I'd probably treat him, Roger, but I probably wouldn't give rituximab. I'd give MMF.
Yeah.
Roger.
Yes.
So if we believe that SAP has a pathogenic role in this disease, Glaxo is conducting a trial using an anti-SAP monoclonal, and will be interesting to enroll some of these patients on that trial. They're currently looking at the role of this monoclonal in SAP-mediated cardiac amyloidosis, but will be worthwhile looking into it.
That's a really, really interesting idea. It's not a nephrology trial; it's a cardiology trial, or?
I don't know.
Yeah, that's a really good point. That's a really good idea. maybe I'll stop there and leave it there. But I think that we don't know what to do. But I think the general consensus is we should try something. And a trial is not, it's a trial. No, we don't think anything's going to happen quickly, but we do want to maybe try to do something at some point. I want to thank everybody, especially Chris, for joining us. It was a real treasure to have you here and to hear the whole story, how it developed. We can't thank you enough. Bill, great presentation. Neelam, great read. Thanks everybody for the comments, and we'll be in touch.
And hopefully I told your
Thanks,
story
guys.
today, Dr. Larson. Thank you.
Oh, yeah. Thanks for the invite. I enjoyed it.
Chris, you're great. Thanks for coming.
Bye.